So welcome everyone to this webinar on antimicrobial resistance in conflict settings, exploring linkages. This webinar is co-hosted by the Fleming Initiative and ISAC, the International Society of Antimicrobial Chemotherapy. My name is Ola Abbara. I'm a research strategy advisor on AMR and armed conflict at the Fleming Initiative and a consultant in infectious diseases at Imperial Healthcare NHS Trust in London. The Fleming Initiative was jointly established by Imperial College London and Imperial College Healthcare NHS Trust. It brings together scientists, policymakers, clinicians, commercial partners and the public to provide equitable solutions to AMR at a global scale. So please do visit our website and the resources that are available on it. We are very pleased today to co-host with ISAC, which is a federation of affiliated member societies, including BSAC in the UK, which seeks to increase the knowledge of antimicrobial chemotherapy, clinical microbiology, and infectious diseases through various activities. The aim of today's webinar is to bring together experts across disciplines who've worked extensively on AMR in different conflict and humanitarian settings, bringing first-hand insights and experiences over many years of work and analysis, and what actions must be taken to tackle this urgent issue. Our expert panelists were authors on a recent Nature Antimicrobials and Resistance publication called Unravelling the Linkages between Conflict and AMR, and we will share this link in the chat. So why are we bringing this expert panel together today and why? And why now? Globally, we not only see the threat of AMR as an urgent priority, but also the increase in the number and complexity of armed conflicts around the world, with profound impacts on civilians, healthcare, environment, animals, agriculture, water and sanitation, and of course the burden of diseases, many of them closely associated with antimicrobial prescribing and resistance. As of 2024, there were more than 33 countries around the world affected by armed conflict, and more than 120 million people forcibly displaced from their homes, many of them as IDPs. We saw widespread attacks on healthcare and major interruptions to healthcare access around the world, including to diagnostics and antimicrobials, which are essential components of understanding and tackling AMR. And all of these have catastrophic impacts on health, on healthcare access, and of course the populations we serve. We argue that conflict does not occur in isolation and that it acts as a catalyst to the development of AMR through multiple drivers. Some of these have similarities to low resource settings or contexts where health systems and governance is destroyed and weak, but there are some important differences, and this is what we seek to address today. And so it is through this lens that we explore this topic. I'm very pleased to introduce our panel of experts that cross many disciplines and across many spheres and work in many different conflicts and humanitarian crises around the world. And I think among them, they have many decades of experience exploring this topic, but also collaborating together. So we have Richard Sullivan, who is co-director of the Centre for Conflict and Health Research at King's College in London. We have Claire Shortall, who is the AMR strategic lead for MSF Amsterdam. Crystal Moussali, an MSF epidemiologist in the Middle East Medical Unit of MSF Lebanon. Antoine Abou Fayyad, a microbiologist at the American University of Beirut in Lebanon. Wim Swijnenberg, a humanitarian disarmament project lead at Pax for Peace in Amsterdam. Mohammed Zaman at the University of Boston in the United States. And Umar Diwachi, a professor of anthropology at Rutgers University in the United States. We have been very ambitious in bringing together such a large number of experts to this discussion, but we feel it's really important to bring the diversity of thought so that we can move forward in understanding and tackling this problem. The format of today will be 3 to 5 minutes of questions and answers to each of our panelists, then plenty of opportunities, we hope, for our audience to engage. Scanning the audience list, I already see that there are many experts among you, and we would love to hear from you and the expertise that you have been working on over the last few years. So what I would like to do is start with a question to Umar. So Umar, you have worked many years exploring this topic, both historically and through the social sciences lens, exploring how AMR interacts with different conflict settings and the experience of wounds and wounding, with a particular focus on Acinetobacter and Iraqibacter. So I'd like to go to you for a first sort of statement or question around your perspective around this topic. So over to you, Omar.
Thank you so much, Ola, and welcome everyone to this panel. I'm really happy to be here and sharing this conversation with my friends and colleagues here. So I was told it's a 5 minutes, so I ended up writing a kind of my intervention. So I'll bore you a little bit with reading it, but I've titled it "Antimicrobial Resistance and the Afterlives of War." So I come today to this conversation as a medical anthropologist working at the intersection of war, medicine, and global health. My intervention is grounded in ethnographic research conducted over the past 2 decades in Iraq and in Lebanon, where I've traced how war shapes microbial life, medical infrastructure, and the politics of care. In our Nature review, our interdisciplinary group set out to examine antimicrobial resistance, or AMR, not just as a biomedical problem, but as something far more complex, a historical, ecological, and political crisis. My own contribution to this project came from years of studying a bacterium that became notorious during the US invasion of Iraq, Acinetobacter baumannii, or as it came to be known, Iraqibacter. This bacterium spread through battlefield wounds, evacuation chains, and field hospitals. But what caught my attention was not only the microbe, it was the world that made it possible. The collapse of Iraq's healthcare system, decades of sanctions, the looting of hospitals, and the patchwork of humanitarian aid created a perfect storm for resistant infections to emerge and circulate. And this is where ethnography becomes essential. In many of the places I work, there is a profound scotomas or blind spots in scientific and clinical knowledge. We often lack surveillance data, laboratory diagnostics, or comprehensive treatment records. But ethnography allows us to see what is otherwise unseen: how families manage infections when antibiotics fail, how clinicians improvise in the absence of protocols, how trust in medicine erodes when healing is uncertain. Ethnography can eliminate these gaps, not as noise, but as data. It reveals how people navigate microbial risk in contexts shaped by war, displacement, and institutional breakdown. And it shows us that antimicrobial resistance is not only a microbial or a pharmacological issue, but a deeply human and historical one. In Iraq, I saw how the problem of resistant infections was not just about misuse or overuse. It was about the impossibility of proper use. Doctors faced with open wounds and no labs, pharmacists dispensing whatever was on the shelf, patients crossing borders in search of treatment. All of this formed what I've come to call war biology, the way war organizes the conditions of life down to the microbial level. This is not just the story of Iraq. AMR today is disproportionately affecting populations in conflict zones in Gaza, in Yemen, in Sudan, Syria, and yet these are often the places where scientific knowledge production is thinnest, where the crisis is most acute and the data is least available. So we need to ask what happens when AMR emerges in places that science cannot easily see, and and who gets to narrate this crisis. This is why interdisciplinary work is essential. Our article brought together anthropology, microbiology, clinical practice, humanitarian analysis, but most importantly, it opens space for reorganizing the forms of expertise that emerge from lived experience, from patients, doctors, aid workers, and researchers on the ground. To respond meaningfully to AMR, we need more than metrics. We need methods that can capture the complexity. We need stories, histories, and structural analysis. We need to understand how AMR travels, not just through misuse of antibiotics, but through the ruins of empires, the afterlives of war, and the uneven geographies of global health. In short, AMR is not a problem that can be fixed with stewardship alone. It is a historical condition, one that ethnography can help us to see. Thank you.
Thank you so much, Omer, and a very convincing argument about why we must go beyond the biomedical, that we must engage with social sciences, and we must engage with the history of the evolution of AMR in these settings. So before we move to Richard, what I would like to do is just say we have deliberately not gone with any slides. So you're not missing anything if you can't see the slides, because we want to keep this engaging and conversational. And secondly, please use full use of our Q&A function, because there should be plenty of time for our speakers to answer questions that you would like to highlight. So Richard, if we go over to you, you have done a tremendous amount of work at the interface between civilian and military approaches within conflict. And of course, you have worked a tremendous amount on things around antimicrobial resistance in many of these settings. Could you give us some insights around your perspectives about some of the key drivers and some of the key issues that we face with AMR in conflict?
Arla, yes, thank you very much indeed, and very good afternoon, ladies and gentlemen. I want to pivot from what Omar said to maybe reflect the importance of interdisciplinarity. And I guess from our perspective at the Center for Conflict and Health Research, we take a much more sort of securitized viewpoint around AMR. And just to sort of layer some detail onto this, for example, we do a lot of work around understanding the interface between the West's counter-AMR strategies and what's going on in China. Now, of course, we're in a highly contested environment at the moment with China, yet they have some of the most advanced technologies when it comes to phage technologies, and also their role in general surveillance systems like the Global Antimicrobial Resistance and Use Surveillance System. So at one level, there's a lot of interdisciplinary work with political science, international relations, and national security to understand how we can better deconflict areas like this, which need geopolitical alliances, multilateral alliances, in what is otherwise highly contested. At the operational level, I think most of our work's been really focused on what we'd consider to be medical intelligence, security, and health. And particularly, I want to focus maybe on Ukraine and the work we've been doing there as part of the sort of civil-military axis. This is a long-running, complex conflict, but it typifies what we consider to be heavy armor modern warfare. The casualties, and by casualties I don't mean those killed, but those still alive but were injured from a military perspective on both sides, are now well over 1 million. So this represents an enormous reservoir and driver for AMR, both in the West, from the Ukraine into Central and Eastern Europe, and through into the rest of Europe, but also from the Russian side as well. The conditions as well have been very interesting, because it's maybe, in this book, I'm sure we'll go into more detail, it's really typified a lot of the problems we see in other parts of the world. It's been very difficult to extract casualties from the front line. Typically, it takes something like 7 to 10 days to pull a casualty out of the front line because of the counter-drone, counter-battery, counter-EM work you have to put in. There's a lot of discrepancy in the use of antibiotics and surgical intervention, so we're seeing a lot more biofilms than we've done in other traditional military conflicts. And of course, the military casualties then get moved staging posts, both through Ukraine and Russia, and then onwards into other countries. And the issue really is, how on earth do you create the transdisciplinary environments where you can have safe harbors to move information out of a highly securitized, classified world into a more open source analytical world in order to understand exactly what Omar was saying. What are the spreads? What are the real threats? Where the drivers really come from? And where can we intervene? Because without that, what we're seeing is very compartmentalized civilian and military sector insights into AMR rather than actually joining the dots together. And I think Ukraine's going to be probably one of the really big test cases, because the sheer amount of data that's being captured both on military and civilian casualties and the rates of AMR, but that much of that has yet to see the light of day. And I think that's going to be where the really big challenge is. And it speaks to data paucity in an environment which is heavily securitized. Thank you very much, Ala.
Thank you very much, Richard. And I think you've reminded us once again why we must be viewing this holistically and not working in silos, whether it's civilian or military silos, environmental silos, agricultural, veterinarian silos. And I would argue that the Fleming Initiative and others on this call have been doing a lot to bridge many of the gaps and many of these linkages, as we sought to do actually in the paper that was published. So Claire, can I go to you next? So you've been a humanitarian and a clinician working with many different contexts over the years, from Iraq to Lebanon to Northern Africa. So could you give us some insights from your work around some of the clinical and humanitarian challenges, noting that Richard highlighted some really important issues around surgical care and treat and transfer approaches when it comes to, I guess, the early phases of understanding and managing AMR. So over to you, Claire.
Thank you. So at the moment, I'm very privileged to be working in MSF with experts across IPC, nutrition, pediatrics, WASH, and antimicrobial stewardship, kind of tailored for humanitarian contexts, and also a team dedicated to getting access to diagnostic microbiology in humanitarian contexts, including the development of tools and resources such as Antibiogo and toolkits to support this. But I think most of, and what I lent on a lot for this paper was really actually the longest trajectory I've had through other NGOs in different contexts, as you mentioned. I've worked in Iraq, Ukraine, Afghanistan, Yemen, in different contexts of conflict, displacement, and also now more in looking at access to diagnostic microbiology for children with severe acute malnutrition in Nigeria and neonatal sepsis in South Sudan. But my perspective, and I have to, a lot of what I will say, it will be a very bad rendering of what Omar's just said, is that I'm actually not an infectious diseases specialist. I'm a pediatrician by background. The last decade, I've been doing this more broader medical humanitarian role, and that's kind of what I've tried to bring to the discussions that we've been having. And it's been through this role that I've increasingly realized that AMR is an inherent risk within pretty much all medical humanitarian activities we do. I've seen it kill kids, delay wound healing. It drives families into deeper poverty. And it's often, as Omar and Richard both say, is something that most of my humanitarian career I've really not been able to see. There's a lack of tools, there's a lack of access to diagnostics, there's really isn't the data there. It's really with MSF that I've been able to see much better. But even then, I feel that currently, faced with these really unprecedented times, some of the, well, definitely darkest days of my humanitarian career and humanitarian shifts, I echo what Omar says. It's not so much a microbiological problem, but really a problem of access to effective care that we're seeing currently. And I would pick on kind of 3 points from a kind of more humanitarian clinical aspect. One is that fundamentally prevention is better than dealing with the consequences. Shoring up the foundations of WASH, access to the expanded program on immunizations, nutrition, having primary healthcare there, and community health activities that actually engage with communities is a real gatekeeper or in this crisis. It kind of stops the mass overload. I've seen, for instance, in contexts like Afghanistan in 2021, when we had the IEA takeover and the sudden cessation of all aid to Afghanistan, well, not all, but most aid to Afghanistan, we saw this very spiraling of malnutrition and infectious diseases within the responses that we were running at the time. And you can really see this kind of catalytic effect, as you said earlier at the very beginning, which I've seen happening from infectious diseases in general. And obviously this is happening within the context of AMR as well. Another thing from my experience has been really the importance of anticipation. And I think that goes back to really understanding what risks are within humanitarian contexts to be able to better mitigate. The more in the past I've been able to anticipate, and you can't always anticipate, but we do try as much as possible, the more we can mitigate. And that really helps us with our response. And the final point I made, which was a point that kind of we collectively made actually as MSF through the broken lens, where we tried to really put a face more to AMR within the context that we work in, and about populations, for the populations that we've talked to, some of them, for instance, neonates, children with severe acute malnutrition, people with conflict-affected injuries, also people living with advanced HIV, but the people for whom antibiotics either don't work or they're just not available. There is also this access and excess paradox that exists in humanitarian settings from my experience, and this kind of profound catalyzing impact of AMR when it comes to inequality. And I know my colleague Christelle will talk also about other contexts for which MSF can speak to this. But in summary, I would say that similar to Omar, that our response needs to match the complexity of our realities, and that we need this transdisciplinary contextualized response that's grounded in community realities.
Thank you very much, Claire. That was such a rich answer, and I think there's a lot there. And I'd urge those of you who haven't read the Nature paper to have a look, because the group worked on a diagram which tried to capture the complexity in these settings and and we probably didn't capture every single factor that could be important in understanding how AMR can develop and also spread in these settings. And I'd also like to pick up on something Claire said. Prevention is much better than cure. That includes ensuring excellent WATSAN, but also infection prevention and control and proper antimicrobial stewardship. And this becomes important and challenging at times of conflict. So we just need to look to Gaza, Sudan, Yemen, Syria, and Ukraine for that matter, to understand how many attacks have occurred on healthcare and on healthcare workers, impacting the ability to have proper IPC in some of the most challenging settings that we can work in. And we need to be able to adapt, and we need to be able to find ways that we can ensure at least adequate IPC in these settings. And I think this goes very nicely to Crystal's work. So you've been examining AMR with data, something that's very challenging. I certainly know from the work in Syria, it's very challenging to get robust AMR data. And Richard alluded to the fact that there may be some data, but it's behind walls. It's not necessarily open for us to be able to use, to be able to understand and tackle this issue. So you've worked in Gaza, in Mosul in Iraq, and also other contexts. Could you speak a little bit more about what you've been finding and what you've been seeing through this work? Because I understand that there's been high rates of ESBLs and carbapenem-resistant Enterobacteriaceae in some of the isolates that you've been looking at with some of the patients affected by gram-negatives. So over to you, Crystal.
Hi, everyone. Thanks, Aula, and thanks for the Fleming Initiative also for the opportunity to talk about AMR in conflict settings. I mean, a reality that we face on the ground daily, I would say, in MSF settings. What I would actually like to highlight today, taking the example of Gaza, Palestine, is, and also, of course, touching on the availability or non-availability of AMR data, is the interruption or even the breakdown of supply chains, which is one of the most visible ways, I would say, war impacts AMR. So in Gaza today, there is no access to microbiology, there is no AMR surveillance. So as Omar alluded, we're blind to the AMR situation in Gaza. And this is basically due to two key reasons, I would say. One, there is no electricity, and with no infrastructure, there is no way to run any microbiology activity. And this we know because the infrastructure has been directly targeted by the war. And second, because of the supply that has been, since the start of this war, very irregular, and even in the past 2 months or even more now, humanitarian access has been totally blocked. So which means that besides food and water and fuel and all what we need to prevent infections and work on this aspect that Claire mentioned, there's no medical supply that are getting in at all, which includes lab reagents, IPC materials, and even antibiotics. So, what is one of the main, I would say, consequences of results of this? That the clinicians and the healthcare teams are faced, or they are obliged basically to treat without knowing what they're treating, what pathogens, what type of resistance. So we're treating blindly using broad spectrum antibiotics or whatever antibiotic we have at hand, which we know fuel resistance. And what we know from the data that we have from Gaza from before the war is that AMR in Gaza is alarming. The AMR rate that we used to see in Al-Auda hospital from the MSF data that we have on patients with osteomyelitis, that around 70% of them had multi-drug resistant pathogens. We're talking about also around 70% of Staphylococcus aureus that are MRSA. So now, 2 years into this war, with a total collapse of water and sanitation systems, a total destruction of healthcare infrastructure, overcrowding health conditions, environmental pollution, you name it, like all the conditions basically for the emergence and transmission of AMR, they are there, they are clearly present, but we just don't have a way to measure it or to build evidence around it. And then on top of this, what Richard talked about a bit, what is happening in Gaza and what happens in most of the wars as well is this disruption, if you want, of the surgical pathway of war wounded, from stabilization to definitive surgery. So most of the patients are stabilized too quickly or delayed in stabilization, which is an indicator of a bad quality of closure of the wounds. And we're talking about contaminated wounds, so we're talking about an increased risk of infection. And again, like focusing or zooming in a bit into Gaza, we started from a baseline of around 3,000 hospital beds in Gaza, but now we're talking about around 500 hospital beds for 2 million people that is available, only half of them for trauma. So again, surgical needs and surgical follow-up is one of the biggest unmet needs. If I want to give practical example, in Nasser Hospital in Khan Younis, we are seeing an increased number of patients with significant delays on their surgical interventions. And in some of our MSF clinics, that not MSF clinics, but clinics that we are supporting in Gaza, we're seeing up to 30% of wounds that are infected. And this is also most probably an under-reporting of the real picture there, because we also have many people that are not accessing care at all. So I think in short, if I want to put it like that, wars don't only drive AMR. I would say sometimes they take away a tool that we have to detect it, to monitor it, and to respond to it. So we're left with no data to guide treatment. So inappropriate antimicrobial stewardship, which fuels resistance, and then again, it's kind of a vicious cycle that we're talking about. And at the end of the day, it's the patient that pays the price. So if I still have a few seconds, I think I would finish by saying part of the message that this group also is trying to convene is that we really need to, the global community needs to start thinking of AMR as a core component of emergency preparedness and response. It's not we cannot think about it anymore as a long-term issue that comes, like after conflict, or it's part of the emergencies. So we really need tools that are simple, practical, easy to deploy, rapid diagnostic test, AMR diagnostic tests that are affordable and that can also be deployed with minimal infrastructure. Because we're talking about conflict and unstable environments. Thanks.
Thank you very much, Crystal. So you've covered so much there, which is very practical with regards to both the clinical, the humanitarian, and also touching on things that are much more broad as well. I was once told that in Syria, it took a few years before the signals around AMR during the conflict occurred. But when it came to Yemen, it was very soon after the conflict started to escalate. And we know from what you've said on Gaza and what Richard said on Ukraine, that I think this is something we're going to see more and more of. as in it becomes emergent and urgent almost at the start of a conflict, not something that happens some years later, as we may have seen in the signals in Iraq or Syria, for example. And I'm very happy to be corrected on that if there's different data. Secondly, you touched on something really important around mainstreaming, so not thinking of AMR in isolation. And this becomes really important with what we've discussed more broadly, but also when we think about this in how we tackle maternal and child health, and how we tackle surgical infections and surgical site infections, and how we tackle clinical care much more broadly. And before we go to Antoine, I think there's also something really important about what you started to say. So we know, and I know Vim will touch on this, around some of the broader aspects around toxic remnants of war, heavy metal contamination, and how they may influence AMR. But when we look at our patients, especially in places like Gaza and the start of the Syrian conflict, and in Sudan as well, sometimes some of the surgical approaches where prosthetic materials are either inserted in less than sterile conditions, which can happen sadly in many of these settings, but also the fact that you do have prosthetic material, which may in itself be a risk factor with biofilms, Pseudomonas infection, other infections as a cause of infection around these areas, infection of these prosthetics, but also as a driver of AMR directly related to the patient. And we know from some of our work on Syria, where we interviewed patients, just how catastrophic this can be for them and impact how they can access healthcare and also the disability that is often associated. What I'd like to do next is go to Antoine. So Antoine, you are one of the foremost microbiologists in this field based in Beirut. You've been studying this a long time. In a context where we struggle to get data, you have done remarkable work analysing, doing advanced analyses, also some of the samples you've been able to get your hands on, and really taking this conversation forward in a very meaningful way. Could you speak more about the work that you have been doing, collecting some of these samples and your understanding of microbiology and AMR as it relates to conflict?
Hi, Ola. First of all, thank you for the opportunity. Thanks to Fleming's and to ISAC as well, and to the 148 participants to give us their time to hear what research we've been doing on this topic. Basically, we've been looking at drivers of AMR in conflict, and we've been trying to see is it really the case where Acinetobacter thrives in conflict? Does it become the more dominant bacterium, yes or no? How does that happen? And why does it become more and more resistant to antibiotics very quickly without any alarms and without any signs? So basically, we've had plenty of theories, and we've tried to collect as many samples as possible from the region during previous conflicts. However, during the last conflict in Lebanon, we've been actually doing quite a lot of work on the antimicrobial resistance in the south of Lebanon. Before the conflict, we've been actually doing quite a lot of sampling from 7 or 8 hospitals from the south of the country. And within a year of collection of samples, the conflict started, and what we started observing was the rise of percentage of Acinetobacter, the creep up that we could see once the conflict started, especially with the escalation of conflict, when Acinetobacter jumped from 18 to 20% of the cases in the ICU to 68 and 72% of the cases in the ICU. Very quickly, a rise of Acinetobacter in the infections. And what we also observed was the rise of antimicrobial resistance in these samples. However, not the ones that you would observe normally in nosocomial infections, right? It's the ones that you wouldn't anticipate you would get, because if you want to look at it from an easy way or from a simple way, usually when you have a nosocomial outbreak, the samples, they come from the same environment. They are usually the same sequence type, they are the same international clone, they have a similar antimicrobial resistance profile. However, during conflict, we start observing something called polyclonality. So we start observing samples that are polyclonal. They have different sequence types. They have different antimicrobial resistance profiles. And then we started observing carbapenem resistance, but there is a lack of carbapenomases. And this right there was the alert to us. We've always thought that heavy metal contamination in the environment during conflict can play a role as a driver for antimicrobial resistance, but we've never really managed to find clinical samples that actually have that profile until the last conflict in Lebanon, where we've collected over 40 or 50 Acinetobacter baumannii isolates from war-wounded patients who the samples are polyclonal. They have different sequence types and polyclonalities. The interesting part is they are carbapenem resistant, but there is no carbapenemase genes. And we started targeting and seeing which efflux pumps are involved in that. And is the heavy metals the main driver to that? Because we know from history of science that heavy metals used to be used as antimicrobials back in the past, and they have the ability to kill bacteria. And bacteria can become resistant to anything that causes stress on it. So we drove down that road, down that path, and we've been really tying the knots and trying to understand how heavy metals can be the main driver and why polyclonality is the observed output of Acinetobacter baumannii. We're still working on understanding why Acinetobacter thrives. Yeah, hopefully we will be able to disseminate this knowledge and data to the scientific community in the near future.
That's brilliant, Antoine. That's a phenomenal amount of work and very advanced work in a field where actually data is relatively sparse, or certainly data that's out in the public domain is sparse for us to be able to track and understand the evolution and development of these issues. What I'd like to do next is go to Vim and then Mohammed. And just as a reminder for everyone, there is more time for you to put questions in the chat. And thank you for those who have already put in some really excellent questions and very insightful questions there. So can I go to Vim next? So you've been working with PACS for many years. Could you tell us a little bit about PACS, but also some of the work that you have been doing around antimicrobial resistance and some of the environmental aspects? Because we've just heard from Antoine about some of the sort of heavy metal perhaps influencing the development of AMR. But could you speak to some of the work around this and also some of the implications of your work as we look forward?
Yes, and thanks everyone, and thanks Ola and the Fleming Institute for organizing this. Yeah, so PACS, I work for a Dutch peace organization, and the reason why we started working on the environmental issues of war was because of our colleagues from our partner organizations from Iraq were concerned about were concerned over the health impact from the various conflicts that have going on in Iraq since the 90s. And these kind of concerns were driving us to fully better understand what could be potential sources that have impacted health of communities in Iraq. But what during that course of the work, we also noticed the complexity of dealing with the different kind of conflict pollution sources, what is putting stresses on people's health, what they're being exposed to, what is driven by the direct impact of the conflict, what's a result of the collapse of management and governance, including health governance in the conflict. And Omar did some really great work on that. But this particular lack of data of how conflicts are leading to environmental pollution and civilian exposure drove us to better understand what could be done to map these different kind of pollution sources. So that's what we started doing to address this data gap of conflict pollution, looking at what are certain pathways of exposure, what are exposed populations, and what can we do to understand, to map these kind of things. So we started off in Syria with developing this open source model using remote sensing and open source investigations to look at some direct impacts of conflict and long-term implications of conflict and pollution. And this is also in the course of this work, we got in touch with all the brilliant researchers from this group as well, because it gave us an additional interest to look at the specific pathways of AMR, because we've seen, of course, and the issue in Iraq was that big concerns over the use of depleted uranium munitions by the Iraqi population, which is like a heavy metal, which is also slightly radioactive, and people feared that exposure there led to a lot of health problems. But in the course of our work, we saw, of course, other kind of sources of pollution that could have impacted that, and other reasons why health problems occurred. Looking at sort of the direct impacts, we were able to sort of piece together the different sources. Look at, like, we have to think of direct impacts and indirect impacts. So when looking at direct impacts, think of urban damages like wide-scale destruction of built-up areas with creating a lot of debris and dust that infects wounds. This dust often is contaminated with asbestos and heavy metals. For example, in Gaza, we have now over 70% of all the build-up areas been damaged or destroyed, with over 53 million tons of debris. In the Ukraine, the number of houses will be likely higher that have been destroyed over the conflict. So you can imagine all displaced populations being exposed to that, first responders being exposed to contaminated dust in wounds. Then, of course, as Antoine mentioned, munition fragments. So it could be blast wounds, could be direct impacts from bullets that are into the body, both from civilians and the military. And also where the direct impacts are like damage to hazardous facilities like industrial sites, fossil fuel infrastructure, that leading to a direct exposure and long-term contamination with heavy metals and other pollutants. But also you have to look at sort of indirect impacts of conflict that can lead to environmental pollution and exposure. So we've seen, of course, in different conflicts, in particular now in Gaza, the damaged water infrastructure leading to sewage spills, contaminated water resources that people are drinking or is getting into wounds or people are exposed to. We see widespread collapse of solid waste management with a lot of debris, plastics that are or solid waste piles that are creating risk for communicable diseases as a pathway for exposure. But also there are very specific conflict resources, very specific resources in conflicts that are unique. For example, in Syria, we have tens of thousands of small makeshift refineries where people, in particular children, are used to be working on a daily basis, where hundreds of them are still operational. Most of them are shut down. So that's like a specific lens. In Ukraine, we have tens of thousands of destroyed military vehicles with risk factors for groups such as scrap metal workers that have to deal with exposure to heavy metals and other toxics in those kind of areas. So you can see the complexity and very different pathways and exposure to pollutants from civilians that can create or contribute to AMR and also a lot of other health problems. So to trying to answer your question on what's needed. So I think we have now the ability to build a more granular level detail of how wars impact the environment, what pollution sources they create, who could potentially be exposed, and what can be done to prevent it. So I think that's very important, and that always has been lacking, to include this kind of data into the analytics, both for humanitarian responders, for post-conflict recovery efforts, because it can be helpful for prevention or mitigation of exposure risk. What we need is also better environmental monitoring and sampling to see the level of exposure. And it can also be helpful for health surveillance to take into account these kind of pathways and vectors if they do this kind of health surveillance programs. And in general, I think this also leads to more discussion over military responsibility on targeting, on providing funding for cleanup and remediation efforts, for awareness raising, in particular in post-conflict situations for civilians, and have sufficient expertise available for looking at WASH infrastructure, but also longer-term recovery that helps to faster remediate potential sources and have this discussion of conflict pollution and responsibility. So that's what we're trying to aim. I think this group is very helpful in bringing together this kind of expertise and understanding of the complexities of wars, conflict, and AMR.
Thank you very much, Wim. And thank you for those who are asking questions. Please, could you, when you put questions in, please pop it into the Q&A, because it makes it a lot easier to moderate and I can only do one thing at a time this afternoon. So for our final speaker is Mohammed, before we go into the Q&A. So Mohammed, you've done a lot of work in different refugee and displacement settings and conflict settings. And more recently, your work has been around microplastics in AMR in terms of sort of environmental contamination, which often occurs or co-occurs in areas of conflict. Could you speak more about this work, and also what is it that we should be advocating or working towards to address some of the issues that have arisen over the last 3/4 of an hour?
Thank you so much, Ola, and thank you to everyone for a rich conversation. I won't repeat some of the wonderful things that were said by my colleagues. I want to talk a little bit about sort of the broader environmental contamination that often occurs in these communities. And it is not simply because of weapons, but also the socioeconomic impact of people living in tight quarters and impacted by poverty and socioeconomic injustice. And one dimension of that is environmental injustice and environmental pollution. So some of our recent work has looked at the simultaneous effects of metal contamination because of conflict and weapons of war, as was mentioned, alongside microplastic contamination that is seen because of excessive use of cheap plastics, or people burning plastics, or people burning tires and things like that as well. So that has been quite disturbing, to say the least, where we've seen even in lab studies that small amounts of microplastics, which are ubiquitous in urban slums, urban informal settlements, but also in refugee camps and in conflict settings, would lead to multi-drug resistant pathogens. And these are very stable mutations with intergenerational effects that we see in several bacteria. What we also see is that there is a synergistic relationship between plastics and metals that is largely unexplored, or rather underexplored. The reason it is troubling is that we have seen from AMR and others that these are multidimensional system level problems. So even when we are looking in the environment and we are looking only at metals, that is going to give you one particular aspect of the challenge, which is because of conflict and use of heavy weapons and all of that. But some of the other parts, which are coming from, as I said, socioeconomic injustice, excessive use of plastic, poor quality plastic, burning of that, is going to lead to similar or perhaps even worse outcomes in infection. So we already have some concerns around that. The second problem with this is that oftentimes plastic gets sort of mixed with wastewater or even flowing water and would impact downstream communities that may or may not be in camps as well. And as we see some of that, we have reasons to be concerned on that. And again, this is something that we are looking at. To be specific, we've done some of this work in urban informal settlements with stateless communities in Pakistan. We've done some work in Sudan, a little bit in Egypt, some in Dadaab camps as well, and some along the migration corridors. As we know, communities are moving from one country to the other, sometimes traversing 3, 4, 5 countries. In the country that I'm in right now, United States, communities would move from sort of these horrendous places, which are impacted by violence or gang violence, and would have to go through Darien Gap and other places and pass through 3, 4, 5 countries. So you're really seeing the impact of this along the migration corridors as well. The second thing I want to sort of talk a little bit about in a minute or so is the need for mathematical modeling. So Wim talked a little bit about sort of remote sensing and other tools. I think that is important because oftentimes, as we've talked about, and Antoine also mentioned, the data quality is incomplete, sometimes unreliable, sometimes not particularly useful to paint a bigger picture. And in that case, one needs to really stitch it together, so to speak, using modeling and projections, not just what has happened in the past, but what might happen should this thing continue for another year or another 5 years. The case in point is Gaza or Sudan or even Syria. As the country starts to go through different phases, what can you project forward that can be valuable in terms of policy? So I'll stop here. I know there are lots of questions. I'll put the open access paper in the chat, but happy to answer any time from any of the colleagues here.
That's superb. So thank you everyone very much. I feel like we've covered a whole range of different topics and brought in different aspects. There's a few things that are striking. It's the complexity of this topic. It's the multiple drivers, the need to contextualize, the need to center communities, the fact that actually what we're talking about is not only of high clinical relevance or a clinical topic, it also relates to both social and political, and for that matter, securitization issues as we discuss it. There's an excellent range of questions. What I'm going to do is try and answer as many as that we can, and I'd like to direct these to one of our panelists. So if our panelists want to answer a particular question, please let me know. But what I'd like to do is start with Latifa's question. So her question is AMR in conflict areas one of the principal sources of the spread of resistance of microorganisms to antimicrobial agents? And if Antoine is able to speak, I think you're best placed to answer this one. But otherwise, if any of our other panelists would like to answer this one, and just while Antoine can see if he can get back on camera, perhaps I can have a stab at this, which is to say, I don't think it's as straightforward as that, because we know that AMR globally is increasing, whether in high income settings not affected by conflict, whether in other low resource settings, whether they are or aren't affected by conflict. But also the other thing that I'd like to bring in here is, I think often we like to put countries into neat boxes, but countries often don't fit into neat boxes. I can say that, for example, in Syria, within Syria's borders, there are multiple geographies with differential impacts in terms of the effect of the conflicts, in terms of the intensity of conflict, attacks on health, remnants of war across the country, but also perhaps some differences contextually and locally with regards to AMR within the borders of these countries, but also regionally. Antoine, would you like to add more? So we're answering Latifa's question here around, is AMR in conflict areas one of the principal sources of the spread of resistance?
So, see, the thing is, if we take what all of us have said so far, we notice that it's a multifaceted issue. It's not just the issue of heavy metals or the issue of microplastics or the issue of lack of infection control. It's all of those put together, and it's all of those working together against humanity, shall we say, because the gravity and the issue of antimicrobial resistance is, I believe, is still taken in a bit is a bit taken lightly at the moment. It's still not being taken pretty serious. Imagine going back to pre-antibiotic era where people could die from simple paper cuts because there is an infection that you cannot cure, right? So the drivers of AMR in conflict are all multifaceted. Yes, there is heavy metals play a role, lack of infection control, lack of lab staff, the short expiry date, antibiotics that are dumped in areas where antibiotics will be distributed amongst all, whether they need them or they don't. All of this is an issue, and it's is a problem. And one of the things that Muhammad Zaman mentioned, which is very important, this is something that we're trying to analyze as well, is how stable are these mutations in AMR when it comes to conflict that we are observing, because efflux pumps don't target one type of antibiotics. Efflux pumps usually are multi-drug efflux pumps. They target several classes of antibiotics. So if you activate one, you could gain resistance to 4 or 5 different classes of antibiotics. So this is something that we're trying to analyze and understand and see how really this is happening, and to really weigh out which driver plays a bigger role. I think, I mean, this is my own personal opinion, but I think they all play the same role. They are all equally guilty in driving AMR in conflict.
And thank you very much, Antoine. And so that we can move forward, but I just want to highlight also, we may want to look at certain bacteria. So Umar and Antoine's work on Acinetobacter is very important there. And actually, arguably, conflict is very important for that particular bacteria, perhaps more so than some of the others that we deal with. I think the next question is best directed to Vim and Mohammed, and this is from Rory at the University of Manchester, around wastewater-based epidemiology can be extremely efficient method for monitoring real-time AMR data in a scalable and relatively ethical context. Do you know if this approach is currently being used in conflict-affected areas, and what do you think the greatest challenges and limitations are here? So, Mohammed, would you like to go first? And Vim, please tell me if you'd like to add here.
Sure. So this is actually a really good question. So we have started doing some of this, less in conflict, more, I would say, in refugee camps. One of the challenges, and sort of in migration corridors as well, as I mentioned, there are two challenges here. The first one is that in some communities, the community themselves are moving. So you get wastewater sample and information about people who may or may not be there, right? So you have to do it frequently enough so you can stitch the pieces together to make sense out of that. That's the first question. The second one is an ethical one. So what? You find something, can you do something about it? And that is absolutely essential to any intervention. You cannot simply say, oh, there is a major problem here, we should just know about it, but not sort of complete the circle as well. So one has to be careful in making sure that when you do find these things, you're able to sort of act and intervene rather than sort of just do it for the sake of knowledge. The third part is, of course, the technical part. You need to make sure that the people on the ground who are doing it very well, and you can do some of it locally because it's quite complicated to send the sample back to London or to Geneva or to Beirut or to Pakistan or wherever, right? So you have to have some capacity to be able to do that. But it's a really good idea, and I'm happy to talk to the colleagues there because we've just started doing some of this work in these places.
And fantastic, Mohammed. And I would also draw your attention to Marwan Osman's work in Lebanon and refugee camps with Ismat Qasim as well. So perhaps not directly conflict related, but certainly displacement and conflict affected. Vim, would you like to add anything to that?
Just for the monitoring perspective, that I think you can identify potential risk areas by looking at like the water infrastructure network, looking at the damages, monitoring, using remote sensing to monitoring the floodings in particular areas. So, for example, we saw one case in Idlib where from Idlib city, all the wastewater was directly dumped into the river that was accumulating in a big reservoir, which was close to a groundwater well area. So that's like a sort of indirect consequence of conflict. And when it comes to damages in Gaza, there's potential to map flooding of certain sites from wastewater. That can inform doing the epidemiology better, I think. So from the data perspective, to locate where it is. Yeah, so I think that's from a mapping perspective and an identification of selected sites, and that's part of the health surveillance and monitoring that could be definitely useful, and also to visualize those kind of risk factors as well.
And thank you very much. And actually, there's some excellent water and sanitation organisations, Geneva Water Hub being one, where they do very good work, and some of their work interacts with antimicrobial resistance as well. And I'll draw your attention to the fact that in 1 week, we have a similar webinar, but slightly different panelists, because it will be held in Arabic, and Professor Suha Kanj will chair, and we will have one of our Gazan microbiology colleagues speaking about her work in sampling some of the water sources in hospitals in Gaza pre-conflict. So I'd urge those of you that speak Arabic to also attend that one as well. The next question I'd like to direct to Richard. So this is from Jessica Hodgkin. It's a very important question, which is around how can we build functional, practical relations between the academic communities with large humanitarian groups such as Rotary to leverage both groups' resources to address conflict in AMR? And I'd also like to direct to you Alvaro's question, which is AMR being weaponized? Loaded question there, Richard.
No, yeah, a very loaded question. Maybe I'll deal with the second one first of all. I think generally speaking, if you ask it in a broader sense in terms of violations of international humanitarian law, not treating patients properly, not allowing decent care, etc.? The answer is yes, in its broadest sense. But is it being weaponized in the sense of the way that water facilities were targeted in the Yemen? What was happening up in northern Syria? No. But what we're seeing is more broadly, though, a weaponization of health per se, whether it's in the infosphere, etc. So, in a sense, AMR is part and parcel of all that. In terms of the first one, it is really hard. We sit on having big meetings about, transnational collaborations. This takes a lot of leadership. It takes a lot of drive, and it does take funding to do this. And as I'm sure everyone listening will know at the moment, funding for these sorts of partnerships is in short supply. Everyone's having to cut their cloth in international organizations because of the implosion in US funding, and also the fact that overseas development assistance, something like 10 billion has been wiped off if you compare it to 2023. But there needs to be better relationships between these individual groups. I don't have a magic solution to it. Personally, I would prefer relationships as well across the security boundaries, because as I said before in my opening remarks, there's a lot of data being picked up by AFRICOM in the NAMRUs, etc., that is simply not being interfaced with the civilian world at all. And I think we could learn an awful lot more. And to be honest, I don't know whether there's any WHO colleagues on. I've just been at the World Health Assembly, and I was kind of told point blank that conflict, Richard, not the biggest problem in terms of AMR. The biggies are China, India, Brazil, Nigeria, the demographic leviathans. Making the case still for conflict as being a really serious supercritical threat for AMR as a driver, I think still needs to be made. I think we need to do a lot more work, because the mood we use it wasn't being focused on conflict as a major driver.
That's great, Richard. Thank you very much. And you can see that Suha Khan just put a couple of really important points. She's an infectious disease consultant, also at the American University in Beirut, with first-hand experience of dealing with these things in conflict settings. So I will draw on her to speak shortly, because she's made a couple of really important points around some of the bacteria and approaches seen. But in the meantime, there's a question here for Omar. So Katie Davis says, thank you for your powerful words. How can we transform surveillance systems to be more sensitive to these root causes and structural drivers of AMR?
Well, that's a very good question. It's very difficult to move from this kind of micro surveillance of AMR that we think with in hospitals to a kind of a much broader multi-sectorial kind of surveillance system. I would say that I think maybe, first of all, diagnosing the diagnostics of thinking kind of on these structural levels is going to be first very important. One of the things that I think kind of emerges in these places is really kind of a collapse of surveillance, not only within this hospital setting, but in a broad way. And I think kind of what Richard was saying, in the sense of this information becomes suddenly securitized, and so we actually we lose real data when there is war, because labs fall apart and surveillance becomes a kind of a secondary problem. No one really is focusing on it. So there's that kind of pathway of loss of surveillance. But then there is what Richard was saying is the other path, which is suddenly that information becomes highly securitized, militarized, and then it just suddenly also becomes invisible. So I think this is a kind of an important point. And I think identifying that there is this kind of breakdown in surveillance or the lack of data or the breakdown of data is a kind of a first step in building a broader system that can recognize how to address the AMR problem. Now the big elephant in the room is what do we do? Do we say conflict is really completely bad, we shouldn't really go to war because it is really driving the AMR problem, or we gonna be saying, oh, we just have to do conflict with more attention to the spread of AMR. I mean, it is a little bit of a weird paradox, because at the end of the day, we are dealing with destructive forces, destructive on humans, destructive on infrastructure, destructive on environment. So I don't necessarily feel like I answered the question, but I think kind of the problem is just understanding how information becomes invisible in these settings is a kind of a first step in trying to figure out how we can actually build better surveillance systems at both the micro level and the macro levels.
That's great. Thank you very much, Omar. And I think it's really an important point, thinking of surveillance not just through quantitative data or epidemiological, microbiological data. Now, if Professor Kanj would like to unmute, I think I've given you the ability, because I think you make two really important points in the Q&A function. So I don't know if you want to highlight some of these issues, and I think we might need to keep it relatively short because we want to finish at 1:15. So over to you, Suha.
Yeah, thank you very much, Ala, for organizing this important webinar. So just a couple of things. I think one thing that Tony was talking about, and we've noticed over the past war on Lebanon, is that patients, as they come to the emergency room within a day or two, we had Acinetobacter baumannii that was resistant to everything, which really highlight, unlike what had been said in the past, that this is a nosocomial pathogen. It really reiterates that this is a community-based pathogen, and perhaps all the things that Tony talked about and the heavy metal exposure, etc., could be fueling the resistance and left us with really no options to treat these injured patients. The other thing I also mentioned is that during this war, we've seen some organisms that we had not seen before. One example would be Bacillus cereus, where we had like a cluster of 8 cases of this organism that we don't tend to think about when we are dealing with injured patient and require different type of treatment with different antibiotics. And most alarming is when we started seeing the multi-drug resistant fungal, filamentous fungal pathogens acquired during these injuries. So we've had a mix of mucormycosis, but even aspergillosis that were resistant to even a drug such as amphotericin B, which we think of as a very broad spectrum antifungal agent. So just highlighting these two things. And just about the wastewater, we do have expertise in the country. People do wastewater surveillance on AMR. They've done that with COVID-19, but also on AMR. And we're developing a program to be able to do that. So hopefully this also will lead to some meaningful work. Thank you so much.
And thank you very much, Suha. And just to say, Suha is the president of ISAC, and she'll also be chairing the Arabic language session next week. We have some more questions that I really would like us to answer, but I think we've only got 5 minutes, and I think we might need to start wrapping up. But what I might do is go to each of our panelists and just ask, what do you think the sort of key message or the key takeaway that you want our audience to take from today? So I'll just pause to give you a few seconds to think about that. And then what I'll do is go across my screen. So shall we start with Richard?
I think my key message is we still have to make the case continually that conflict is a major, major driver of AMR, and it's deeply, deeply underrepresented in the research agenda globally. And we've said this again and again and again. It comes back to what Omar was saying about the interdisciplinarity. We need a lot more to unpack this and to understand what's driving it, and also where do we intervene if we can, to be honest. I think that's my key message.
Thank you. And can we go to Omar next?
Sure. I guess the key message is that we need to rethink how we understand AMR, not only as a biomedical problem, but really a kind of a historical condition. And we have to understand how conflict is part of that history that drives transformation in our ecological systems, in kind of human microbiomes relations, and also in the kind of conditions of our own hospitals. The main message is that we need to think of AMR through a much broader lens that brings in microbiological and macro kind of analysis to understand this really dangerous future killer of humanity.
Thank you, and arguably current and future killer, very sadly, in many of these settings. So can we go to Claire next?
Yeah, so I think my message, taking a bit from Omar again, that is about changing the narrative. We really need to change the way we talk about AMR. We need to stop talking about it as a microbiological chronic issue, and we need to start realizing what it is to the populations that, I mean, for me, that I've worked with historically. And that to do that, we need to have a transdisciplinary way of looking at that, combining all the lenses and kind of coming up with context-adapted solutions so that we can anticipate, but also respond. And we do need to engage much more with communities and the things to come from that level.
Cool. Thank you very much, Claire. And then Crystal.
Yeah, I think a bit aligned as well with Amar and Claire's. I think we need to continue to frame as much as possible AMR as a quality of care issue. Basically, again, that needs, yes, multidisciplinary efforts. And we need to make sure, I think, that it also remains high on the global agenda, because at the end of the day, what also we can gather from all this talk is that we need more evidence, we need AMR surveillance, and for all of this, we need also like equitable and also long-term fundings to be able to work on all those issues as well.
Absolutely. So investment and system strengthening approaches and resilience of our health systems and processes beyond health systems, of course. Wim.
Yeah, I think the message from our side would be to, if you look at conflict pollution, AMR should be as one of the potential risk factors where people have to deal with and being exposed to, which add another pressure on populations in need. And there's a necessity to fully understand like what different kind of sources are, pollution sources and exposure, and also necessity for states and warring parties to take it into account in both in the military planning, but also in post-conflict recovery and humanitarian assistance, to make sure that to work on prevention and remediation for affected populations.
Fantastic. Thank you very much, Wim. And then Mohammed.
Thank you so much. So I won't repeat what others have said. I fully agree. I think one of the things that we should think about is the educational component of this. How do we train our students? How do we train our historians? How do we train our social scientists and data scientists? I think there's still tremendous need for that. And in general, this is very siloed. I don't think my students read work by historians or by artists, and vice versa. So I think this is something that continues to be a challenge in training when we think of interdisciplinary aspect. The other thing I would say is there's the need for basic science as well. We are making lots of assumptions here in terms of discovery, and there's a need for laboratory science to really sort of integrate well with what you're seeing in the community. That gap can be fairly challenging and oftentimes can result in people doing the same things that may or may not be what we are seeing on the ground. So I'll just stop here.
That's super. And Antoine, I don't know if you're available, but we are quarter past the hour now. So I think it remains to me to firstly thank all our panelists. Richard had to go because he's traveling, but he passes on his thanks to the co-panelists, but also the audience for such brilliant participation, brilliant questions. And I really feel that we were able to have a high-level discussion on this really key topic. And I look forward to more collaboration, discussion, but also some challenges to what we are discussing and what we are thinking, because I think this is the way that we can continue to formulate the ideas and hypotheses that can take this work forward. So I would like to thank ISAC and the Fleming Initiative for all their support bringing this webinar together. And once again, please do register for the Arabic language one in 1 week's time, which Crystal, Umar, myself, Suha, and others who are part of the audience and on this call will be joining. So thank you very much, everyone, for joining today. Bye-bye.
Thank you. Take care.